So you can see on the diagnostic arthroscopy there is complete ACL tear. Apart from that, we are also having medial and lateral meniscus tear and MCL tear in this patient. Hello, I am Dr. Prateek Joshi. Today I am going to show a video of arthroscopic ACL reconstruction, MCL reconstruction, and medial and lateral meniscus repair surgery. So as we go in the medial compartment, there is no need for pie crusting because there is MCL tear already. So we have good enough space in the medial compartment. You can see that the joint is quite good since the patient is young in age. There are no arthritic changes. So we are going to repair this meniscus tear, which is in the posterior horn of the medial meniscus in red zone. We are going to use one all inside device to repair this posterior horn medial meniscus tear. So I have introduced slotted cannula through the entromedial portal through which I have introduced my all inside device. I'm going to take bite from the superior capsule, and as you can see I have deployed the first implant, and once the implant has been deployed I'm going to gradually withdraw the device and I'm going to engage the substance of the posterior horn of the medial meniscus in order to deploy my second implant posterior to the meniscus and the capsule. So both implants have been deployed and the sliding locking knot is being tightened, and you can see that the meniscus is quite stable right now. One stitch should be enough in this kind of tear because it's a small tear involving posterior horn of the medial meniscus. You can see that the meniscus is quite stable and this has good healing potential. So now we'll go towards the lateral compartment, and as you can see there is under surface tear involving posterior horn of the lateral meniscus, and we are going to repair this with one all inside device. So I've introduced my all inside device and I'm going to take my first bite inferior to the meniscus through the posterior capsule, and I have reduced the distance which I'm going to pierce because there are neurovascular structures right posterior to this region. So we need to be very careful not to pierce too much and not to overshoot the capsule. Once I have tactile feeling of piercing the capsule, I am going to deploy my first implant. The first implant has been deployed and now I am gradually withdrawing my all inside device, and now I am going to target the inferior portion of the posterior horn of the lateral meniscus. As you can see I am gradually piercing the substance of the meniscus, and once I have tactile feeling of crossing the posterior capsule I am going to deploy my second implant. The second implant has been deployed and now I am pulling the thread to tighten the sliding locking knot. So this completes the posterior horn of the lateral meniscus repair. Here again we need just one stitch because it's a small tear, and now I'm going to cut the thread. This completes the posterior horn lateral meniscus tear repair. So now we go towards the ACL reconstruction, for which I have introduced my femoral femur from the entromedial port, and I'm going to drill the guide wire through the femoral femur to the lateral femoral condyle. The guide wire has been drilled through the femoral ACL footprint in the lateral femoral condyle, on top of which I am going to drill with the end-over-turn drill bit. As you can see, based on the marking on the end-over-turn drill bit, the length of our tunnel appears to be around 38 millimeter. So now we measured the depth of our tunnel, which is around 38 millimeter. Now we are going to drill on the guide wire with 8 millimeter drill bit because that's the diameter of our graft at the femoral end, and we are going to drill up to mark of 20 millimeter because that is the length of the graft that we want to keep in the femoral tunnel. Now I am using the ACL tibial jig to drill the guide wire through the tibia in the ACL tibial footprint. As you can see, the guide wire is exactly in the anatomical position as it comes out from the ACL stump. Now we are going to drill with 9 mm drill bit over the guide wire in the tibia because that's the diameter of our graft at the tibial end. Now I have introduced my adjustable loop endo button attached to the graft that we have prepared with the peroneus longus tendon, and as we are pulling the adjustable loop from the tibial tunnel to the femoral tunnel, the mark that you see on the adjustable loop endo button is made at 38 mm because that is the length of our femoral tunnel, and at this point we are going to flip our adjustable loop endo button. The button is flipped, and now we are going to cinch the graft from the tibial tunnel to the femoral tunnel. So as you can see, now the graft is traveling from the tibial tunnel to the femoral tunnel. We'll stop cinching the graft once the mark of 20 mm reaches the outer mouth of the ACL femoral tunnel. So now the graft is fully seated in the femoral tunnel, after which we are going to do cyclic loading of the graft and then fix the graft at the tibial end with the interference screw. So this is the picture of final ACL graft after it has been fixed at the tibial end with the interference screw. You can see that it's quite strong and it's in its anatomical location. So this is going to provide good anterior and rotational stability to this patient. Thank you.